my presentation today about hyperuricemia and CKD patients. My debate was my brother, Professor Khamis, and this is our disclosures. My agenda today about uric acid metabolism and excretion, kidney involvement in hyperuricemia, comorbidities associated with gout and hyperuricemia, effect of urate lowering therapy in CKD, treatment, and lastly, by guidelines. Uric acid is the end products of urine metabolism. Urine metabolism comes 20% only from exogenous sources and 80% from endogenous sources. Then after excretion through GIT 30% only, and through the kidney 70%. Journey of uric acid through the kidneys 100% filtered with journal filtration rate. Then after exposed to reabsorption and secretion through a lot of transporter located on the apical and basolateral membranes. 90% will reabsorb it, only 10% will be excreted, and this is the 24-hour urine concentration of uric acid. Generation of uric acid ions and the monosodium urate, and the monosodium urate hydrates from uric acid appears, and this is the crystal needle-shaped soluble monosodium urate precipitate as monosodium urate crystals past its saturation point. Such saturation point is at 37 Celsius is 6.8. Histopathological finding on chronic acid uric acid nephropathy on the graph on the left side showed fragments of uric acid crystal in atrophic tubules, while on the right side clear crystals imaged with polarized lighting. And this is the mechanisms of uric acid-induced kidney injury. Also, kidney injury could be through hyperuricemia, either genetic predisposition or purine increased intake or overproduction or reduced excretion of uric acids. So we have urate monosodium urate deposition with urate nephropathy or nephrolysiasis, and the inflammation can lead to chronic kidney disease. On the other side, indirectly, with asymptomatic hyperuricemia, endothelial dysfunction, RAS activation, reactive oxygen species, and inflammation also can lead to chronic kidney disease. The Japanese studies, prospective cohort study, including around 49,000 patients, Japanese, risk of renal failure increase with hyperuricemia. Also, hyperuricemia can predict end-stage renal disease. Also, risk of dialysis according to the baseline uric acid as clear here. Another study from Nehannes from USA, including around 5,700 adults, hypertension and CKD also correlate with serum uric acid. Also, obesity and diabetes correlated with hyperuricemia. Another narrative review for gout and hyperuricemia comorbidities from Finland. Uric acid is not only concerned with the kidneys, the systemic disease, including the eyes, joints, liver, cardiovascular, CNS, and kidney, of course. This is a longitudinal analysis and the mean review come from China, including around 700 patients. The patients were divided into 4 uric acid categories as a cutoff 6, 8, and 10. Their studies showed a higher uric acid level is associated with significant rapid decline in estimate GFR and higher risk for kidney failure. And this is the violent plot of the distribution of baseline serum uric acid level by CKD stages. And this is a distribution of the proportion of baseline hyperuricemia status. Another study from Japan, changes in the serum uric acid have reciprocal effect on estimate GFR change. A 10-year follow-up study of community-based screening in Japan. Their studies suggest that maintaining serum uric acid and the normal range is important to maintain estimate GFR decline within the normal range. Another study, baseline serum uric acid level to target in gout, including around 1,200 patients, reduction of uric acid associated with the reduction of the total cardiovascular event and the cardiac mortality and the total mortality. Also, reduction of serum uric acid level to target is responsible for decreasing the decline in estimate GFR And also from Iceland, from Sweden, another study including around 1,200 patients, lowering serum uric acid less than 4 milligram per deciliter, including centenarians, compared to other around 40,003 patients, are responsible for twofold greater clearance to a chance to live to 100 years. Another systematic review and meta-analysis effective uric acid lowering therapy on renal outcome in CKD patient with asymptomatic hyperuricemia. The figure showed effective uric acid, of course, reduction of uric acid level due to therapy, and the effect of changes in the GFR in favor of using urate lowering therapy. Another study from Brazil is a meta-analysis of randomized controlled trials, including 18 randomized controlled trials of CKD patients. The population shared around 2,500 participants. Reduction of uric acid associated with slowing the CKD progression and reduced protein and albumin excretion. The figure showed effective uric acid therapy on the serum uric acid in favor of treatment. Also, estimated GFR declining by follow-up and by CKD stages in favor of using treatment. Also, proteinuria reduction in favor of using treatment. Another systematic review and meta-analysis from Spain about the effect of uric acid reduction on chronic kidney disease, including 29 papers. Also, reduction of uric acid and prevent the decline of the GFR and prevent the increase of serum creatine level. Also has to prevent also a level of proteinuria in favor of use treatment. As regarded treatment, this is the guidance for our doctors, what the drugs to avoid, especially alcohol or high fructose syrup corn oil, sugar, and others. This is the management of gout and CKD, including flare and prophylaxis. Also, urate lowering therapy. You have allopurinol, febuxostat, azancine oxidase inhibitors, and uricase. Also, uricosuric drugs, but we have to avoid in CKD patients. Special concern about using these drugs in CKD stages 3 to 5. And this is a consideration in dialysis because for people after dialysis, no need for that treatment unless there is gouty arthritis, and you have to monitor the level of uric acid with the usage of xanthine oxidase inhibitors. This is the Japanese guidelines about the management. They classify the patient either gouty or not gouty. Gouty, you have to go to lifestyle and you have to give therapy. For how long? Until absence of tophi and serum uric acid less than 6. You can stop treatment after 6 years. On the other side, if the serum uric acid asymptomatic, I mean no gout. If the serum uric acid less than 8, you have to go to lifestyle. But if there is serum uric acid is more than 8 with another comorbidities like kidney disease, diabetes, or heart failure, you can go to lifestyle and treatment. If these comorbidities are absent, they are giving only treatment for serum uric acid more than 9. As regards the KDIGO guidelines, they recommend to give treatment for symptomatic hyperuricemia, but they suggest not using agent to lower serum uric acid in people with CKD and asymptomatic hyperuricemia to delay CKD progression. But this, as you see, is suggestion and of weak evidence D. At the end, many thanks for your attention.